So I laid out the 3 options for you, and which one do you want to try?
I don't like the idea of taking something every single day.
Okay.
I don't want to forget my buprenorphine and then I feel sick. I don't want to feel sick ever again. So I feel like I'd rather just get over this one hurdle of feeling sick for a couple of days and then maybe do the Vivitrol since it's only once a month.
Okay. Well, I think that's a great choice. In this situation, the only bad choice is not to use any of these effective medicines, and we're very fortunate that we have different options to choose from that are very helpful for this situation. And doing the long-acting injection of naltrexone is a great idea. So, do you think it's feasible to go to a residential program, or do you want to try to do it as an outpatient?
I think I need to do it as outpatient I don't want to go away for 30 days. That's too much.
Okay. What we would do is you'd be coming into the clinic every day, and we would start off with the first day would be a day of buprenorphine. So what we would do is we would have you not use like from the night before. You'd come into the clinic in slight withdrawal. So in some ways it would be similar to starting a buprenorphine induction, in which we would have you not use like before bed, give you a little something to help you sleep, and then come into the clinic in some slight withdrawal. We'd give you a dose or 2 of buprenorphine, depending on how you're feeling that day. That will make you feel better. But then we're not going to give you more buprenorphine. We can't continue the buprenorphine because the buprenorphine lasts so long. Every dose of buprenorphine you take is pushing off the shot even longer. The next day, we would not give you any buprenorphine. It would be a so-called washout day. Now, I'm going to give you some other medicines. I'm going to give you a drug called Clonidine, which comes in 0.1 milligram pills, and I'm going to have you take up to 3 or 4 of those a day every few hours. You have to be careful with that when you stand up from being seated or laying down, because you can get dizzy from it. Just a side note, during this whole process, it's really important to drink lots of fluids. I don't know what your experience has been in the past, but people in opioid withdrawal tend not to eat or drink that much. I don't know.
I don't have a stomach for anything, yeah.
Right. So, during this process, we're going to encourage you to drink as much fluid as you can, because that will make the dizziness worse if you're dehydrated. Have you ever taken drugs like Clonidine or Xanax or Ativan or Valium, anything like that?
I haven't. I know they help with anxiety.
Right. So you've not had problems with misusing those drugs before?
No.
So I'm going to give you like a small quantity, like every day I'll give you a little bit of some 0.5 milligram pills of Clonidine, and have you take that like twice a day to start and just see how that feels. That helps with the withdrawal. Clonidine is probably the best non-opioid medicine for treating withdrawal, and clonazepam is probably second best in terms of helping with that. We give, there are different things to use for sleep. The insomnia is, for some people, the symptom actually that's most disturbing. Mm-hmm. And so we'll use a combination of some zolpidem, which is Ambien, and if that doesn't work, we might use something stronger like quetiapine, but we usually use zolpidem and something called trazodone, which is kind of like Benadryl. It's like a sedating antihistamine. So we'll give you 10 milligrams of zolpidem and 50 milligrams of trazodone to try to help you sleep. So we're going to give you these other non-opioid medicines to help with the withdrawal that's going to come after the buprenorphine wears off. And so usually what we do is we have somebody be free for 1 day with the opioids. And then, there's a little bit of flexibility what we do next.